Thanks for the invite as well. I'm very happy to present to this group today. And so, yeah, I'm Katie Harron. I'm an associate professor at the Institute of Child Health at UCL, where I've been off and on for about 10 years. And I do a lot of work with data linkage and administrative data. And what I wanted to talk to you today about was how we can use statistical methods to create and evaluate linked electronic or administrative data cohorts to try and exploit the really rich data that are collected about populations of people as we interact with different services through our lives. So anytime we interact with a service, for example, a hospital or a GP, then a record is created. And if we can link these records together over time, it helps us build a picture in some ways, someone's pathway through life. And in my work and in our department, we're particularly interested in what happens prior to and during pregnancy and how this relates to later maternal and child health. So if you think about each of these bars on the diagram here representing a point of interaction with the service, so the dark blue bars might be a hospital admission or an A&E attendance, and the light blue ones might be a GP visit. Then these are time points or events from which we can obtain really valuable information. So, for example, diagnoses and procedures recorded during a hospitalisation, or a blood pressure or BMI measurement recorded in a GP record. But in England at the moment, we don't routinely link information from mothers to their babies because a mother's NHS number isn't recorded on the baby's record or vice versa. So there's no real clear way of doing that linkage. But we found that it is possible to use other information, such as birth dates, geography, and clinical information like gestational age and the weight of the baby at birth, which should be the same on the maternal record and the baby record to link these data together. So this then allows us to look at how maternal factors influence a baby in their early years and beyond, and their hospital or GP or other service trajectories. And we can link in siblings, which gives us the opportunity to do sibling control analyses where we evaluate discordant pairs to account for shared familial risk factors. And we also have information on the pregnancy period and the inter-pregnancy period, or the inter-pregnancy interval. So thinking more broadly, we're beginning to start to be able to take advantage of linking with wider determinants of health, including social environmental data and also educational data, whether that's as an exposure or an outcome. So every piece of information we link together is like a piece of a jigsaw and helps us understand how different parts of our lives fit together. So in my next few slides, I wanted to go through some examples of how we can use these sorts of linked administrative data cohorts. And then I want to talk through some of the challenges or how we do the linkage and some of the challenges with that. And then a step further on, how we deal with uncertainty in the linked data itself. So firstly, we can use these administrative data cohorts to answer questions that are otherwise hard to address using traditional data collection approaches. So for example, there's evidence from randomized controlled trials that early induction of labour before term or before 40 weeks has no adverse effects on the mothers or infants among groups of mothers who are traditionally thought of as being more high risk, so first-time mothers aged 35 or older. But it's really difficult to recruit the tens of thousands of mothers that it would be required to have enough statistical power to evaluate the impact on rare outcomes, such as perinatal death. And this is where administrative data, population level data, really comes in. So for this study, we analysed linked data for 77,000 mothers and found that compared with expectant management, induction of labour at 40 weeks was associated with a 66% lower risk of perinatal death. So this has these findings obviously have quite important implications for policy guidelines and also for women who want to make decisions about how they want their childbirth to happen. So the large size of these data sets is a real advantage. Secondly, because we're linking data from such a long period of time, the longitudinal aspect of the data makes it possible to identify groups who are more at risk based on early indicators of need. And we can do that by bringing together data from the period before pregnancy with information about what happens at birth and in childhood. So these plots come from a study of pre-pregnancy psychosocial risk factors that we did using linked data for 2 million mothers in England. And it shows the relationship between maternal age and then birth rates for the top plot and infant injury admissions on the second plot. So you can see the strong pattern according to maternal age, and generally see that the best outcomes are seen for mothers who are aged between 30 and 35. But you can also see variation according to whether the mother had pre-pregnancy a history of mental health conditions, which is the blue line here, the lowest line for birth rate, or the highest for injuries, or for mothers who had a history of hospital admissions for adversity-related diagnoses, so violence, self-harm, or substance abuse in the 2 years prior to birth. So those are shown in the red lines on the plot. So this is trying to demonstrate that if we can use these data to identify maternal risk factors that will be important prior to pregnancy, and we can do this routinely using large hospital data sources, then we have an opportunity to know which types of groups and mothers and families might benefit most from intervention, and then hopefully ultimately reduce adverse effects for children downstream and burden on health services through childhood. And then a perhaps slightly less obvious benefit of data linkage is improving the quality of the original data sources. This study by colleagues at ICH aimed to understand whether the differences that we see in child mortality rates between England and Sweden, where Sweden has lower child mortality rates, whether that difference could be attributed to the characteristics of children at the time of birth, or whether it's something that we do later that's different between countries that might explain the differences in mortality. But for the time period that they were looking at, information about these key risk factors at birth wasn't complete when looking only at the baby's record. So birth rate, gestational age, maternal age, and then the index of multiple deprivation, which is a score reflecting different measures of deprivation. But by linking to the maternal record, they were able to improve the completeness of these variables quite a lot and increase their cohort from 18% of all births here in the orange to 75% when looking at a complete case analysis compared to what we know are the national birth rates. So that made a huge difference, again, in terms of power and data quality. And along a sort of similar theme, we can use this mother-baby linkage or longitudinal linkage to enhance other data resources. This plot here is based on a study called eChild, which links hospital episode statistics, or HES, so hospital admission data in England, with the National Pupil Database, which contains information about all pupils attending state schools in England. So altogether, there's about 14 million children who are linked in eChild, but this data comes from just 1 year of birth, 2004-5, and shows the relationship between gestational age at birth and the percent of children not achieving expected levels in development at key stage 1 and key stage 2, so age 7 and 11. Around 7% of children who are are born preterm in England, which means before 37 weeks of gestation. And we know that being born even a few weeks too early can still have a quite dramatic impact on a child's development. But evidence from other studies suggests that teachers don't always have a clear understanding of the additional needs of children born preterm. And we don't yet have a clear idea about how gestational age or low birth weight, for example, interacts with other factors like childhood chronic conditions or month of birth even, which can make a big difference in terms of school attainment. So we're using the eChild data to generate evidence on this relationship in a more in-depth way than has previously been possible, again, due to the size and the comprehensiveness of the data. So for example, we're looking at the pattern of gestational age and school attainment and provision of special educational needs for different groups of children, including those who can be diagnosed early with chronic conditions, so that we can understand when the best time to intervene might be and how best to do that. And then final example, I've talked about using linked data for observational research, but it can also be used to supplement clinical trial follow-up. This study was recently published by a PhD student in our department, Max Verfurden, who brought together data from 7 trials of infant formula, which were conducted in the 1990s, and linked those trials with up-to-date current administrative data. So the trials themselves were affected by attrition, and this plot shows the percentage of participants who responded at the latest follow-up. So you can see for the SGA trial, the small for gestational age group, by age 17, only 6% were still contactable. But by linking to administrative data, again, the National Pupil Database, we could increase the retention or the completeness of the data to over 80%. And this meant that Max was able to assess GCSE outcome data according to the original trial arm for babies who were born in the 1990s, and actually concluded that infant formula modifications didn't promote any long-term cognitive benefit compared to standard infant formulas. The axis on this plot relates to the mean standard difference, the mean difference in the standard deviation score. So points below the line show a worse outcome for the treatment arm compared to the control arm. And that was published in the BMJ recently. So hopefully I've persuaded you that there are huge benefits to being able to link these sorts of population data sets. But there are challenges relating to privacy and confidentiality and to data quality. So first, access to administrative data is really time consuming and even more of a challenge when we're requesting that identifiers are released from one data holder to allow linkage to be performed. And it generally means that linkage is conducted by a trusted third party rather than researchers. So there's minimal input from the researchers into the linkage process. Quality of administrative data, as I've already mentioned, isn't always optimal. And this is relevant to linkage because unique identifiers, such as the NHS number, are often incomplete or unavailable. And this is particularly important when you think about cross-sectoral data linkage, because an NHS number wouldn't be relevant in the education data set, for example. So this means we have to think carefully about the types of linkage methods that we're using, depending on what sorts of identifiers are available. So both of these problems can lead to linkage errors, where we fail to link records that belong to the same individual, which we call mismatches, or false matches, where we link records that belong to different people. And even small amounts of linkage error can lead to substantial bias in results. So this means we need to think carefully about how we handle errors when we're actually analysing the linked data. So how is linkage done? As I said, most of the linkage that's done of administrative data is done within trusted third parties or within data providers such as NHS Digital. And they favour a straightforward approach, which is to use deterministic or rule-based linkage. And this algorithm on the side here is the one that was used until quite recently to link hospital records within HES, hospital episode statistics. So every time a new record is made in HES of a new hospital admission, then it would be checked against all the previous records to see if it matched a previous patient. So the first rule is to check whether the record agreed on sex, date of birth and NHS number. And if it didn't, then it would look to see if there are any matches on sex, date of birth, postcode, and then a hospital number. And then it would move down to look just at sex, date of birth and postcode. So this is quite a conservative algorithm because it's unlikely that many people would share this same set of identifiers, with the exception of same-sex twins, which you can probably see from the last one. So by conservative, I mean they aim to minimize the number of false matches. But the trade-off against that is more mismatches. So you can see in this particular algorithm, because sex and date of birth are required at each stage, whenever a record is missing one of those data items, or if there's a mistake in the recording of those identifiers, then that record couldn't be linked and it would be given a new HES ID and it would appear to be a new patient. So to address some of the problems with strict deterministic rules, probabilistic linkage was proposed, which uses information from a set of identifiers and the agreement between identifiers on records in different data sets to come up with a score or a match weight to represent how likely it is that those records belong to the same person. So agreement on something that was quite discriminative or unique, like NHS number, would contribute a large value to the overall match weight. Agreement on something like sex would contribute a positive value again, but it would be smaller, which would reflect that it's less discriminative and you're much more likely to agree by chance on sex. And then disagreement on any identifier would contribute a penalty to the overall match weight. So the values from each of the identifiers are summed to come up with a total match rate or score. And the ways that these are calculated are based on two conditional probabilities. The M probability, which is the probability of agreement on a particular identifier, given records really are a true match. And then the U probability, which is the probability of agreeing on a particular identifier by chance in records that don't belong to the same person. And then the match weight is generated by taking the sum of the ratio of these values, which have been logged to the base 2. And this gives either a negative or a positive match rate. So then you choose some sort of threshold to classify these records, actually in a deterministic sense, to being links or non-links. For linkage of mothers and babies, we had an additional problem because we didn't have access to identifiers. And even if we had as researchers, it wouldn't necessarily have been helpful because a mother's NHS number is different from a baby's NHS number. So you can't use the mother's and the baby's identifiers to link between records. But we know that in HES, along with the main hospital admission record, admissions relating to a delivery or a birth have an additional set of about 20 variables known as the baby tail, which contains fields like birth weight and maternal age and gestational age, which should theoretically be the same for the mother's and the baby's record. So by using a combination of deterministic linkage as a first step and then probabilistic linkage, we can find links by looking at things like gestational age, hospital location, etc. So this plot shows the probabilistic match rates for agreeing or disagreeing on each of these variables. And you can see, for example, if we look at sex, which is R here, there's a small positive value in the blue for agreement. And then for something like presence of anaesthetic post-delivery, which is Q here, then there's a large penalty rate for disagreement. So the way that the probabilistic weights are calculated takes into account both how discriminative a particular identifier is, but also how the quality of that identifier, how likely it is to have been recorded wrong in records that belong to the same person. So I mentioned this trade-off that we have between different types of errors, missed matches and false matches, and that we have to decide on this cutoff or threshold to decide which records to accept as matches and which to discard. So when we want to try and separate these two groups of records, we don't actually know which records are matches and non-matches. That's what we try to identify through linkage. If we choose a high threshold or a relatively high cutoff, then we have a higher positive predictive value. We can be sure that the records we've classified as links really are true links, but we trade this off against missing some of the matches. Whereas if we reduce the threshold, we have a higher sensitivity, we capture more of the true matches, but we trade this off against including some false matches. And the impact of these two different types of errors really depends on the research question and the type of linkage. But if we think about, given we know or we can estimate that we'll have a certain level of linkage error, the next step is thinking about how the results will be influenced. Does it matter? Will it impact on our analysis? Will it lead to any bias? So we've done a bit of work thinking through the implications of linkage error and come up with a list of potential bias. So starting with mismatches, when we fail to identify a link that really should exist, the first problem this causes is missing data. We haven't been able to make a link, so we haven't been able to bring across the information that we were hoping to obtain through the linkage. So the potential bias for that will be determined on whether the data is missing at random or whether the linkage errors were concentrated in a particular subgroup. And the way that the bias might manifest will depend on the way that it's handled in the analysis. For example, if we only included linked records in an analysis and ignored the ones that we hadn't been able to link, then that would be analogous to complete case analysis and might result in a loss of power at least, and maybe some bias depending on the missingness mechanism. So secondly, mismatches can lead to misclassification or measurement error. So if you think of an example where we have a particular cohort and we want to link it to mortality data, if we make the link and it's correct, then we know that a particular person has died. But if we miss the link, then we would misclassify that person who really has died as having survived. So thirdly, if we're thinking about linking to a disease registry, for example, to define a population of interest, we want to only include people who have a particular disease in our analysis. And if we're defining the presence of that disease through the linkage, then missed links would mean erroneous exclusion from a particular analysis. And then finally, we can end up splitting one person's records into many. So again, if we think about hospital records, a missed match would mean that we appear to have two different people who really should have been the same person. So that could look like we have a lot more admissions than we really do, but it could also look like we have a lot fewer readmissions because we can't keep counting the same admissions for the same person. So what are the ways of trying to identify these errors? If we can compare to an external gold standard or another reference data set, then this might at the very least be able to tell us which groups are most affected by errors. So this example comes from Linkage of mortality data for the Swiss national cohort. The blue line is the rate, the mortality rate that was estimated from the linked data, and the pink line here is published national data on mortality rates. So you can see that there's an underestimate. They haven't been able to link all of the deaths, but then something strange goes on in the middle where the linkage is much better in the 2001 year, which I think was a census year. But this distorts the trend based on the linked data. So we need to think carefully about how we interpret trends when the quality of the data over time might have changed in linked data. If we expect all of our records to link, then one very helpful thing to do is to compare the characteristics of linked and unlinked data. This study was looking again at mother-baby linkage, but in an Australian data set. The first column is the characteristics of the matched pairs or the linked records. The second is the unlinked baby records, and the third, the unlinked maternal records. So they found that the outcomes that they were interested in were or records that had these outcomes recorded were much less likely to link. And also that there were differences in the characteristics in terms of births in private hospitals and whether the mother had been born in Australia or in another country. So this can tell us maybe that there was something about the quality of the data from stillbirths and preterm births that meant that identifiers weren't recorded as accurately and they were more difficult to link. Or it might tell us about some sort of associations with the other factors. So maybe it was that births in private hospitals were more likely to be high-risk births that were more likely to have these adverse outcomes, and perhaps the private hospitals recorded data in a different way. So looking at the characteristics of linked and unlinked data can really help us identify where the potential sources of bias might be. And then thinking again about how errors are distributed, this plot shows the readmission rate that we would estimate based on linked hospital records if we missed matches in all groups. So if the purple lines are the true readmission rates and we've underestimated that in our linked data, then that would be represented by the black bars. So this is an example of the splitting that I talked about, where the same person's records aren't linked over time. But in this example, the relative differences between the groups are retained, so we might still be able to make some valid inferences from the data. But if the missed matches affect different groups in different ways, then you can see the relationship between ethnicity and readmission completely changes. So that's about thinking whether the errors that might happen during linkage are distributed randomly or whether they're more likely to occur within particular groups. And ethnicity is one of the groups that we often see a lot of variation in terms of linkage error. So I've talked about mismatches. Now false matches, they can have very similar consequences, but perhaps in different directions. So misclassification or measurement error, erroneous inclusion or exclusion from an analysis, and then the opposite problem to splitting, where we merge multiple people's records into one. And of course, false matches and mismatches don't occur in isolation, and there's always some sort of trade-off. This study wanted to explore this trade-off in an analysis of linked data on mortality and ethnicity in the US. The middle column here is the hazard ratio that they estimated based on their original linkage. But then they were surprised by this finding because they had expected that Hispanic groups would have higher mortality. So they relaxed their linkage criteria to try and link more of the Hispanic groups who they thought might have more complicated name structures and therefore be more problematic to link. And you can see the hazard ratio was significant in the direction that they had originally expected. But when they extended this sensitivity analysis and use a more conservative or specific approach, the hazard ratio was reversed again. Okay, so there are a number of ways we can think about evaluating quality, and I've sort of given some examples of these already. So we can compare with gold standard data, whether that's a subset of the data where we know the true match status or an external reference data set. We can try and find positive or negative controls, so records that we know definitely should have linked within the data, or those we know definitely shouldn't have linked, to estimate error rates. We can compare the characteristics of linked and unlinked records, or in cases where we don't expect all of the records to link, so a cohort to a mortality registry, for example, we can look at the data and look at the records with high and low quality data items. So for particular subgroups, which ones are likely to have more missing data and therefore are less likely to link before we've even started. So that's a useful thing to do. So for example, you can look in the data to see whether men of a particular age are less likely to have an NHS number recorded because they're less likely to interact frequently with hospital services. And we can do quality control checks. So once the data have been linked, we can identify implausible scenarios that don't make sense. So where we link a mortality record and then have a subsequent hospital admission record, that might be indicative of a false match. Okay, so the next step, so we thought about how the linkage is done, and we thought about how the errors might occur and what the implications of those errors are, is what do we do in analysis of linked data? So there are a couple of solutions, although I would say that this is definitely a field of ongoing research. One suggestion, which Harvey Goldstein proposed, was to treat linkage error as a missing data problem. So rather than the aim to be creating one static linked data set that we're certain about, the idea is to think about the analysis we want to conduct and make sure that we're carrying over the correct values from that linkage for that analysis. So to give an example of how this might work, imagine if we had some survey records that we wanted to link with an infection status from a laboratory record. And we have some records that link with a high level of certainty, some where we know there's definitely not a link, and then others where there's a bit of uncertainty. And if we've done probabilistic linkage, then we might have a match rate associated with these less certain records. A deterministic linkage strategy might just take the records that we're confident about, and that would have the same sort of problems as a complete case analysis. An alternative would be to look at the complete cases and to look at the relationship between the predictors and the outcome, or the variables in one data set and another, and use that information to impute the values for the records where we have that uncertainty. So basically this would be where we haven't made a certain link or a certain non-link, we treat the record as having missing values and we impute the data for those missing values. And then to take this a step further, in something called prior informed imputation, we can use the match rates themselves to help inform which of the values should be imputed. And this hopefully means that we carry over the correct value for analysis more frequently. And we would handle it in the multiple imputation framework, where we could create multiple data sets and average results across them. The second approach is to use quantitative bias analysis, where we estimate linkage error rates, mismatches and false matches within subgroups if necessary, to work out what the answer would have been in the presence of no linkage error. And then we can see how much linkage error would be needed to change the interpretation of our results. So say, for example, we had 10,000 cohort participants that we wanted to link with cancer registrations, 5,000 in each socioeconomic group, so a high group and a low group. And in this case, we have linked 110 of the high SES group with a cancer record and 100 of the low SES group. So that would give us an odds ratio of 1.102. But say we know that we had a linkage sensitivity of 80%, so we'd missed 20% of the matches. And we know that if we've missed a link to the cancer registry, we've misclassified that outcome, then we could think about reassigning unlinked records according to our estimate of the mismatch rate. So this would, in this case, change our odds ratio slightly, but not our interpretation of it. So that's assuming that we have a constant linkage error rate across the high and low SES groups. If we don't have that constant linkage error rate and we have differential linkage error, so say we have linkage sensitivity that was 0.99, so we'd missed 1% of the matches, then we could again reassign those records, and this in this case would give us an odds ratio of 0.885. So the idea with quantitative bias analysis is to use a plausible range of linkage error that we've estimated through any means, apply that to the data, and come back with a range of realistic scenarios for our outcome of interest. So it gives us the opportunity to test a range of assumptions and to see what impact different levels of error might have. Okay, that's it. To summarize, I think linkage of electronic data is extremely valuable and will continue to be so, particularly following the opening up of more data sources in the past couple of years because of COVID. It can be much more efficient than traditional follow-up in terms of the time and cost associated with creating new cohorts. And we need to be aware of data quality and linkage errors and how they might challenge the reliability of our results. Probabilistic linkage methods can be useful to give us measures of certainty, but we need to keep in mind that mechanisms for linkage errors can be complex, and to try and really think through the implications of that for our analysis. And then methods for handling linkage errors are available, as are guidelines for how to report linkage studies in a transparent way.